Violence review for the PMHMP ANCC exam, and this is a recap of the PMHMP Review and Resource Manual 4th edition, Chapter 17. This chapter deals with a psychiatric mental health nurse practitioner's role in identifying and treating clients who are impacted by intimate partner violence, sexual assault, homicide, and suicide. Assessment of lethality will also be reviewed. These issues may co-occur with the disorders already discussed or may present in clients with no other identifiable psychiatric or mental health problem. They also may be frequent findings in primary care settings while working with clients with just general medical conditions. Intimate partner violence. Description. It's a physical, emotional, economic, or sexual pain and injury that is intentionally inflicted by a person's intimate partner. The goal of the abuser is to establish power, manipulate the other person, intimidate the other person, or control them. Etiology for intimate partner violence. Characteristics of abusers are personality disorders such as antisocial, narcissistic, or borderline. Some environmental stressors could be financial difficulties, ending of a relationship, and unemployment. Intimate partner violence occurs among heterosexual and homosexual couples. Intimate partner violence is the leading cause of injury to women ages 15 to 44. So intimate partner violence is the leading cause of injury to women ages 15 to 44. So cause of injury. It is the leading cause of death among African American women between the ages of 15 and 24. So the leading cause of death for African American women ages 15 to 24. 1 in 10 female high school students in the United States have reported violence from their dating partners. 1 in 10. 15 to 25% of pregnant women are physically abused. 22 to 35% of all women seen in the emergency room experienced injuries as a result of intimate partner violence. 1 in 3 women and 1 in 4 men are victims. 50% of homeless women experience this type of violence. 63% of men incarcerated for murder between the ages of 11 and 20 have murdered their mother's abuser. I'm going to repeat that. 63% of men incarcerated for murder between the ages of 11 and 20 have murdered their mother's abuser. 33% of male abusers are well educated and include men in professional jobs. Risk factors for abusers are exposure to violence at an early developmental age, low self-esteem, social isolation, lack of support, cognitive impairment, and physical or financial dependency. Prevention and screening. Public education and awareness beginning in high school, social programs, at-risk family education, community education, stigma reduction to allow victims to come forward, signs and symptoms of being the victim of abuse, prevention programs, early recognition, intervention, and initiation of treatment for the victims, and routine screening for victimization at all healthcare settings. So, routine screening for victimization at all healthcare settings. Assessment. Interview the person who has experienced the violence alone. Determine primary caregivers, living arrangements, and legal custodian. For history, assess the following. Determine recurrent history of medical treatment consistent with abuse, accidents, suspicious or repeated fractures, physical injuries, traumas, refusal of ongoing treatment for follow-up, missed medical appointments, and determine environmental, psychosocial, and financial stressors. Physical exam findings. Monitor nutritional status for dehydration and malnutrition. Look for lacerations, bruises, wounds, burns, or fractures. Look for poor skin and personal hygiene. Mental status exam findings. Findings of traits and behaviors suggestive of experiencing abuse are fearful, evasive, guarded, depressed, passive, and dependent. Diagnostic and laboratory findings. There are none specific to abuse. Determine the general health and nutritional status of the person. Some differential diagnoses are accidental injuries, mood disorders, anxiety, substance use disorders. Clinical management. Most state laws mandate reporting of suspected abuse and neglect of vulnerable populations. Those include older adults, people with disabilities, and children. Pharmacological management, there are none specific to this intimate partner violence. With regard to non-pharmacological management, the safety and medical well-being of the person experiencing the abuse is the most important. Refer the person to a domestic abuse shelter when feasible. Help the person develop a safety plan. And all of the following are about a safety plan. Assist the client in developing a code word for the family and other support system as an attempt to inform them that the person is in need of help. Advise a client to tell one person in his or her support system about the situation. Advise a client to pack an emergency bag and hide it in case of the need to leave quickly. Advise the client to keep the intimate partner violence hotline and other telephone numbers such as the police department, counselor, and shelter in a secure place. Monitor medical status as symptomology presents. Monitor nutritional status and vital signs, and suggest psychotherapy to assist in gaining insight and in developing new coping skills. Suggest hospitalization when in the best interest of the client. Sexual assault or abuse is any sexual act or penetration committed through coercion or physical force. This includes rape, incest, sodomy, oral and anal acts, and the use of foreign objects. It is an act of violence and humiliation as expressed through sexual means. It is used to express power or anger. The etiology for abusers. Character disorders. Behavior after violence is reinforcing, such as once done, they're likely to repeat, and social exposure to violence in culture, media, and at home. Incidence and demographics. Women have a greater incidence of being assaulted than men. Sexual assault is the most common form of abuse. Perpetrators are more frequently men than women. Sexual assaults are often committed by fathers, stepfathers, uncles, other siblings, other family members, and men that women are dating. Alcohol is involved in 30% of all rapes, and only 1 in 4 rapes is reported. Factors that increase incidence of abusing. Substance abuse disorders, psychiatric disorders, divorce, family or personal history of physical or sexual abuse, long-term exposure to violence, social isolation and lack of support systems, environmental stressors such as unwanted pregnancy and an intimate partner, unemployment, or financial difficulty. Prevention and screening of victims. Public education and awareness campaigns, community resources and support, community emergency shelters, helplines, and safe houses. Assertiveness training and self-defense, early recognition, intervention, and initiation of treatment, routine screening at all healthcare settings. Assessment. Interview persons who have experienced the assault alone when possible. Establish a safe, trusting relationship to promote sharing. Routine inclusion of questions concerning sexual assault in medical history. Interview alone and not in the presence of the family, friend, or partner. Interview for social history, including history of living arrangements and relationships. Physical exam findings are nonspecific. The presentation of traits and behaviors consistent with potential for having suffered sexual assault or other abuse are withdrawn, frightened appearance, hyperactive to touch. Associated findings are unexplained bruises, abrasions, cuts, lacerations, burns, soft tissue swellings, and hematomas. Sexually transmitted diseases, genital rash or discharge, rectal tissue swelling or discharge. Physical signs that are strongly suggestive of sexual abuse in children. Lacerations, ecchymosis, and newly healed scars of the hymen, no hymenal tissue in the 3 to 9 o'clock area, and perianal lacerations. Remember that any child presenting with concerning physical signs should be evaluated by a sexual abuse expert. A complete history and a sexual abuse examination need to take place. Mental status exam findings: withdrawn, frightened, anxious, scattered appearance, hyperreactive to touch, and dissociative. Diagnostic and laboratory findings are nonspecific. Assessment and documentation labs are forensic specimens, pregnancy tests, rectal, throat, and vaginal cultures, screening for sexually transmitted diseases such as syphilis, HIV, hepatitis B, herpes simplex, human papilloma, HPV, trichomonas vaginalis. Differential diagnoses are accidental injuries, consensual sexual activity, lichen sclerosis, PTSD, and an anxiety disorder. I didn't remember what lichen sclerosis was, so I looked it up, and I'll just read the description that I found. It's a chronic condition that causes white patches of skin, usually in the genital area. This condition occurs primarily in girls who haven't started menstruating and in postmenopausal women. Lichen sclerosis is thought to be related to genetics, immune disorders, trauma, or infection. Lichen sclerosis can cause discomfort, itching, and easy bruising or tearing of the skin. So that's a differential diagnosis. So clinical management: use sensitivity and respectful care, be aware of legal reporting requirements, and use available community resources. So I've always known as a nurse in Florida that I was a mandated reporter, and I looked into it just to make sure. So psychiatric nurse practitioners in Florida are also mandated reporters per the Florida law. What needs to be reported is any form of child abuse or neglect, or suspected. Per the Florida law here, it says if the report contains information of instance of a known or suspected child involving impregnation of a child under 16 of age by a person 21 of age or older, the report shall be made immediately to the appropriate county sheriff's office or other appropriate law enforcement agency. Also, sexual battery is something that requires a person who observes a sexual battery or who has the ability to seek assistance for the victim without being exposed to threat or physical violence must make a report. Also, vulnerable adults. So section 415.1034 states that any person, including but not limited to any state, county, or municipal criminal justice system or law enforcement officer who knows or has reasonable cause to suspect that a vulnerable adult has been or is being abused, neglected, or exploited shall immediately report such knowledge or suspicion to the Central Abuse Hotline. And then who do we report it to? It used to be, there's two options. So there's still the option of calling the 1-800-96-ABUSE, but most, what's a lot easier and painless is going to their DCF website. I don't know if I listed that there, but reportableabuse.dcf.state.fl.us. That's usually easy. Plus, it's a paper trail of your exact words that you used to notify, and also it connects your. Well, the phone does it. The phone, I'm sure, tracks all of this the same, but I just feel more comfortable using the online site. And then what happens if you don't report is failure to report child abuse to DCF is a third-degree felony. Failure to report a sexual battery is a misdemeanor of the first degree. And failure to report a case of known or suspected abuse, neglect, or exploitation of a vulnerable adult or preventing someone else from doing so is a misdemeanor of the second degree. So those are super important things to know. Mandated reporters under the Florida law. Psychiatric mental health nurse practitioners are mandated reporters under the Florida law. Non-pharmacological management. Ensure safety and well-being, ensure confidentiality, complete accurate documentation, assess for potential suicidal ideation if the person is showing any depressive symptoms, suggest cognitive behavioral therapy, offer support groups, and assist with access to criminal and legal supports. So we don't just refer, but we assist them. We assist them to get access to criminal and legal supports. Lethality assessment. Lethality assessment is an evaluation, screening, or testing. Lethality refers to the likelihood that a person will commit suicide or homicide, and it's focused on violence at the extreme. Violence, the behavioral expression of anger, rage, and hostility that is demonstrated by the use of physical force directed toward persons, in the case of suicide, towards self or property. Violence in school. Serious physical fighting with peers or family members, severe destruction of property, severe rage for seemingly minor reasons, detailed threats of lethal violence, possession, use, or both of firearms or other weapons, self-injurious behavior or threats of suicide, bullying or being bullied. And when warning signs indicate that the danger is imminent, safety must always be first and foremost consideration. Action must be taken immediately. Immediate intervention by school authorities and possibly law enforcement officers is needed when a child has presented a detailed plan, time, place, and method to harm themselves or kill others, particularly if the child has a history of aggression or has attempted to carry out threats in the past, is carrying a weapon, particularly a firearm, and has threatened to use it. Suicide risk assessment. Risk factors are depression. Also, the black box warning on all antidepressants for children, adolescents, and young adults up to the age of 20 or under 24. Prior suicide attempts, family history of mental disorders or substance use, family history of suicide, family violence, firearms in the home, incarceration. Males are 5 times more likely than females to commit suicide. Males are 5 times more likely than females to commit suicide. White males over the age of 85 have the highest rate of suicide. Signs of imminent danger: threatening to hurt or kill self, looking for ways to kill self like weapons, pills, or other means, talking or writing about death, dying, or suicide, plans or preparations for potentially serious attempt. Alcohol use increases the risk of suicide attempts in persons with suicidal ideation. Homicide, early warning signs are prior history of threatening or violent behavior, paranoia or easily panicked behavior, fascination or preoccupation with weapons, particularly weapons or explosives that could be used for mass destruction, such as semi-automatic guns, extreme stress from personal problems or a life crisis, identifying which incidents of workplace violence reported in the media, and either condoning or sympathizing with the actions of the persons committing the violence, being a loner or with little or no involvement with other employees, engaging in frequent disputes with supervisors or coworkers, persistent violation of company policies, obsessive involvement with one's job, particularly where it occurs with no apparent outside interests, volatile or violent home or other personal situation that has the potential to bring violence into the workplace. Threats of violence: throwing objects, making a verbal threat to harm another person or destroy property, making menacing gestures or physically posturing without actually touching the person, displaying an intense or obsessive romantic interest that exceeds the normal bounds of interpersonal interest, attempting to intimidate or harass other people, behavior indicating that the person is significantly out of touch with reality and that he or she may pose a danger to himself or herself or others, volatile or violent personal situations such as found in some custody battles. And then alcohol use increases the risk of violence. Safety, and this is bolded at the bottom, safety is the number one priority, and any threatening behavior must be taken seriously. So this not only concludes the chapter on violence, but it's also the end of the book. I have found the videos to be super helpful to me. I can't wait to continue to listen to them until it's time to take my exam. And I hope that my efforts have also helped somebody else. And good luck to all of us.